Good morning, everyone. I am Ayunder, a fellow at Yonsei Severance Hospital. Today, I would like to present an ECG case conference. This is the today ECG. Wow.
So who will start? Pronto da check. Who will start? Okay, who will start? Olivia is easier, always. Seyon, will you?
Okay. Well, let's suppose this is the tachycardia of rate about 300. It's very about 200 to 300, very bad. And it seems like a white QRS tachycardia, and the axis is one is positive and the 3 AVF is negative. So it's left axis deviation. And the transition is in about V5 to V6.
Next to you.
And V1 is negative and V6 is positive. Well, it's hard to say definitively whether this is VT or SVT. But I think in the AVF lead or maybe in the lead 3, 2 or 3, I think there's some notches on the top, and looks like that those could be AV dissociation.
Which one? Could you point out? Follow the mouse, please.
Like this one to this one and this one. Anyway, this seems like another rhythm is presenting with the bass rhythm. So I think that could be a sign of VT.
Okay. Thank you, Seyon. Once again, I would like to listen to your straightforward interpretation. Okay?
Yeah.
So it seems like
Yeah.
it could be. I don't like this kind of way. Of course, we need to be careful not to be too under certainty.
Yeah.
But when you try to express your interpretation, just straightforward.
Okay.
Then audience will follow you.
Yeah.
Okay?
Yeah.
That's a skill. Okay. Chong, Dr. Nam is here. So your next turn.
I think it's VT.
Oh, VT. Wow. Why?
That seems like VT.
I'm happy to make you confused. Why?
First, with the Gordon 3 square 120. So white QRS.
Could you please remove the bottom? Yeah, it hides the.
You can take it up.
Yeah, full screen now. So now it doesn't make sense. You can interpret it as a VT because it is wide because complex tachycardia, right? Of course, 70 to 80% wide QRS tachycardia might be VT, but the remaining, the 30%, you will miss. Okay. Okay, 5-second rule. Next copy.
So this is a regular broad complex tachycardia at the rate of about 240. There's evidence of AV dissociation. Looking at lead 2. I'm trying to use V6 to estimate the P wave rate, and it's somewhere around 120. So there's this here to this. Here, there's nothing. I don't see any. Yeah, I'm not sure. So maybe about 120. So I don't think the atrium is going that fast. And because of the QRS amplitude, it's difficult to see the transition very well, but I think it transitions from V5 to V6. So I agree with VT as the likely diagnosis for this lead.
So you point out that just the AV dissociation. What else?
AV dissociation.
Because even the wide QRS complex tachycardia, if there is a AV nodal conduction block, it could make a dissociation, even if it's SVT aberration or underlying bundle branch block. Reverse factor is okay, even though could be VT, but if there is a one-to-one VA conduction, it seems like a SVT, right? So we need to try to find out another clues to support VT.
Okay. So the intrinsic deflection time is also quite long.
Long intrinsic deflection time.
Yeah.
Okay.
I'm not sure if the variation in QRS amplitude, looking at V1, for example, and even lead 2, some QRS amplitudes are longer than others. So
yeah,
these are long.
In the middle. Yeah.
These are short. These are long, and that's a feature. I mean, that happens in at very fast heart rate. So given this heart rate of 250 thereabout, I think it's consistent. It's been associated with SVTs, but I don't know if it is specific for SVTs alone. I think just the fact that the heart rate is this fast, it supports the QRS alternate.
Okay, Washim, do you want to argue against VT?
It's a wide QRS tachycardia with LVV morphology and apparent AV dissociation, and the intrinsic wide deflection is notched wide, argues in favor of VT, but nodovascular, nodoventricular tachycardia with VA block is also possible.
Well,
it's possible, while the A is dissociated from V, despite
so
the
still you favor VT.
The common things, probability weights.
So anybody support SVT aberration or bundle branch block? Nobody. Okay. Then, Dr. Che, can you localize if it is VT, can you localize the VT focus?
First, you can see that V23 AVIF is negative. It means that it is came from the lower part. And the transition zone at the V5 or 6. And one to AVL is positive, so it is from the right to
Where?
right side.
RB? Hmm? RB or LB? If you decide it, 성현 will map RB or LB. You like the long procedure?
I agree.
RB. Okay. And where? The reason why RB? And then more specify the location.
I think they don't want to positive and I didn't want positive. The A with negative. So I agree too. But I don't know the localized where.
You should study because you're rotating the electrophysiology. Right?
Okay.
Okay,
I
so
study.
let's interpret one by one. This is wide course complex tachycardia, and as Seong and Kopi mentioned, we see that there's the AB dissociation. If you look at the ST segment carefully, the small notches looks like PA, that it does match with course complex. So it is highly likely VT. Just if you see it's just AB dissociation. But as I told you, AB dissociation is not enough because there's exceptional case of AB conduction block or VA one-time conduction, especially in patients with myocarditis. BT and heart block combined very frequently. So you have to be careful to interpret the patient wide course complex ECG in patient with myocarditis. Okay. Okay. It is VT. Let's localize. This is LBB pattern, right? And the transition is very late. So I think it's coming more likely coming from
Basal RV.
yeah. So RV side, and based on the Stevenson classification, V345, you can localize apical basal location because V345 is located in LV apex, right? If it is an O negative, it could be from apical side. Okay, all positive from basal side. But please make sure this classification is for LVBT, okay, not RVBT. RV is the put above the LV side. So ECG localization is a little different to LV apical basal differentiation and RV side the apical lateral classification. So probably RV mid or basal wall origin BT looks like a very late transition. One more thing, we discussed about the potential SVT with aberration. If it is SVT aberration, ventricular exit side should be basal side, right? Regardless if it's atrial tachycardia, avenue conduction, or bypass trap. Then V345 should be at least positive or transition. So if it's a late transition, it's less likely to be VT. Less likely to be SVT. Okay, so we localize RV basal or mid side, middle origin, and let's localize limb lead, lead on positive, AVF negative. So it is east axis, right? Northeast axis. Okay, then if you remember the echocardiogram, parasternal short axis view, northeast axis is coming from septum, right? Posterior septum. So based on ECG, probably posterior septum or free wall of RV side origin. But the interesting finding is 2-3 ABM shows all negative waves, right? It is the typical example of cross BT. Okay, it could be cross BT or very basal to mid side RVD. But in the right ventricular side, we have only one lead, V1. So the weakness of a standard 12-lead ECG, it can localize right ventricular side easily. Okay, so you need to suspect both free wall or septal side. But if it is septal side, you need to think about the cross PT. Okay, so
Answer is that AVR and AVL are both positive, so they're both posterior leads. So it's likely coming that again favors crux.
Say again, please.
Both AVL and AVR are positive.
Mhm.
So both are posterior leads.
Yeah.
So favors again crux.
Against crux?
Again favors crux.
Favors crux. Yeah. Okay. Please add the comments. The one. Small one. I'm not sure Dr. Chang Wang is here.
Abbreviate, Professor.
Don't say abbreviate. Please challenge it. Okay, anything else? With the expert for BT. So, Dr. Wang, how will you plan to manage this patient?
I'm sorry for like I didn't hear the previous he or she already.
Everybody
Don't know.
does know. Just a simple ECG, and then we are discussing.
Could you check the hemodynamic status? If it is unstable, BT, maybe we need it's part of version, but if it is stable, then you can get treatment for.
Dr. Yundari, can you give Dr. Wang small amount of information? Hemodynamic stable?
Stable.
Hemodynamic stable. Okay. Then
We can check the X-ray.
Yes, we can.
do you have?
I will show you next.
Okay, let's go to the next slide.
I'll show you next slide. Maybe next slide will make some decision.
Oh, is there answer?
Oh, here's the baseline.
Oh,
This is the patient's
Oh.
in the halter. Also noted like reviews ECG strip.
oh, it changed the mainstream of the story. Okay, so now Dr. Please.
Same day,
Same,
3 ECGs
Yes. same days.
are taken in same day. ECG has been changed a lot.
Yeah. Same patient.
Exactly same patient.
It's 1 month later.
Oh, Coffee mentioned this is 1 month later.
The first one was in March.
March.
This is April.
So it's 3 weeks later.
Oh.
Maybe 1 month later.
The ECG taken December.
But the April
December.
monitoring also noted like this reviews 5+ complex. Next time I just including the neuropilon as complex reviews.
What did you do between the ECG, previous ECG and now?
In my opinion, maybe the first ECG, maybe the 1 to 1 macro entry in cardiac
No. He's asking the what kind of management, what changed? Which one changed? So some treatment at this moment, right?
Right.
And how's the management change or the patient condition change? Had it drop?
During the tachycardia, the patient usually take.
Not usually.
Yeah.
We need a fact. Tell us the fact.
Beta blocker.
Beta blocker.
Yeah.
Okay.
And go to the ER.
Okay. So after 3 weeks later,
Mm-hmm.
it's a sudden onset. This tachycardia again.
Again.
So no cardioversion,
No cardiolation.
just a beta blocker.
It's just he occurred syncope 2 to 3 times during the application.
Syncope, recurrent syncope.
Mm-hmm.
Okay. And anyway, in March, the patient ECG changed to sinus rhythm, right?
I can find the sinus rhythm reviews from population procedures, but I can't find sinus rhythm after.
So somebody did the ablation. Dr. Om asking. Then
And I.
okay.
So let's describe these ECG.
Yeah. We need to interpret this issue. Washington, can you interpret the right side panel first?
So this ECG shows an irregular rhythm with RBB morphology, likely, and the P waves are well formed enough to say it's an AT with variable AV conduction with RBB, baseline RBB, and the left panel seems to be a rapid ventricular response of the same underlying AT.
AFib and RBR. Dr. Chan?
That's not really think that the right panel shows no definite regular atrial P wave, and the left side is the heart rate is about the 150, and I cannot see the preceding P wave in front of the QRS complex. Maybe some notching at the V1 and V2 that shows the irregular and very fast P wave.
Are you looking left side or right side?
Left side.
Left side.
Yes.
Okay.
So I think it's the AT or the line AT.
So atrial fibrillation, left panel, is rapid ventricular response,
Yes.
right? And comparing to previous ECG, intrinsic coil deflection time is very sharp, right?
Mm-hmm.
So, anything else? Copy?
Yes, on the left as well, I think so on the left, there's now a right axis deviation. Yes, I think it's wasn't northwest.
Axis is same as baseline.
Yes, and there's still AV dissociation. Intrinsic coil deflection this time is much sharper. So even though AT is a possibility, I don't know the age of this patient, but I think a particular VT would be another differential for this patient, given the right bundle morphology and then the right axis with the AV dissociation. It could also be a fascicular VT as a differential.
But the
morphology is same as baseline. Morphology is similar to baseline.
I never seen the vascular VT with so irregularity. If it is vascular VT, it is reentrant mechanism.
Yes.
So RR also. So you are the raising the another differential diagnosis. Okay, good try. How's the axis of this patient? In the right side panel, it looks like incomplete RBBB. But if you look at lead one axis changes, right? Positive, negative. Okay, so when it shows the wide QRS little wider, axis more right axis debate, right? So it is suggests that it is not a fixed anatomical bundle branch block, functionality. So if you look at carefully, when the QRS is wider, coupling interval is shorter. So that's why it's some part of a ventricle is in the relative refractory period could make a change the degree of a bundle branch. Okay. Dr. Huang. I wonder Dr. Cheng Huang is here. Maybe not. I guess he's in the aircraft. Yeah. He told me he will come to Korea today. Okay. So, any other comment, Doctor? Okay, let's go to the slide. Next slide.
Patient is 22 years old, female, who presented with palpitation and dyspnea. Also, the first symptoms showed around 3 years. And also, she had myocarditis in 2023, and she underwent a muscle ablation you have for around 1 year after procedure. And also she has hypothalamic microcytic anemia, mild degree, and polycystic ovarian syndrome. And also she used bisoprolol 5 mg once a day and rivaroxaban 20 mg once a day. That is the patient's test results. ECG. The patient's still ongoing atrial flutter. Then some doctors prescribed anticoagulant to her. Then she's still using this. Noted. No.
What's your child best score?
Yes.
Why she needs
Before coming here, she's still using this. Then after,
that's the reason for the hypochronic microcytic anemia.
Maybe.
Yeah, in young ladies. So menstrual bleeding is a large amount. Okay, anyway.
ECG showed atrial flutter and echocardiography. Both atrium size were normal and ejection fraction 53% preserved, and increased echogenicity in the mid and apical segments of left ventricular posterior wall, and no thrombus in left atrial appendage and in TE, and cardiac MRI from 2023, focal myocarditis involving left inferior wall, and chest X-ray was normal. Based on these findings, we proceeded with catheter ablation, and here is the patient's after ablation ECG, sinus rhythm, and sinus rhythm has been restored. This was a case of CTI-dependent atrial flutter. They successfully treated with CTI ablation last month during the KHRS meeting. Yeah, thank you for your attention. Yes, May.
I don't understand why
This one.
Is a flutter? Completely different.
Dr. Doschans. Dr. Doschans and the Mongolian colleagues patients. Yes. during the KHR's meeting procedure case. Yes.
First one, I don't agree this is flutter.
Mm-hmm.
Second one, document ECG was atrial fibrillation.
Mhm.
The why is the ablate atrial flutter. Number three, why the patient is taking
Mhm.
redoxon.
I have some EGM pictures,
Mhm.
and during the ablation, atrial flutter terminated, then sinus rhythm restored, and also
Okay, let's discuss about that.
Right.
The patient is atrial fibrillation, and in the EP lab, the patient shows just atrial flutter. Then is it valid to ablate CTI ablation alone?
But we see a lot of times that AFib, AT, AFib flutter, they repeat. Or if another kind of thing, it doesn't rule out other pathology. So you still need to map and then determine whether really it's just a flutter or not.
And in this context, a young female with myocarditis, it is a dynamic picture. This will evolve over time. Is it advisable to go for ablation or do only medical management?
These young patients, based on the guidelines, catheter ablation is recommended. But if the patient shows atrial fibrillation flutter, they are bad cousins, right? So if the cut off the CTI, probably another cousin will be angry and show up as atrial fibrillation. So if the patient has a documented atrial fibrillation, I think the oblate PBI plus CTI might be the valid.
My point is, in the context of myocarditis, these are usually transient.
It is the long time after. Myocarditis was in 2000.
Yeah, 3 years ago.
This is from this year.
Yes, this year.
Yeah. Okay. So is the patient okay?
Oh, no, okay. Symptom free. After this,
at that time, a flutter, but the first ECG suggests VT and MRI supports that.
And also she experienced
And MRI location of LG is also supporting the
syncope, right?
during the palpitation.
Please, Dr. Doksan,
Next time.
follow this patient carefully.
Okay.
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 Okay. Any other comments? Okay, thank you. Thank you. Please smile.
Yeah, we'll start the EGM conference. I'm Min Jung-chae from Severance Hospital. So this patient is 34 years old female and she has the palpitations with the characteristic of sudden onset and terminations, and the duration is about 30 minutes, and she takes no medications, and the echocardiography shows the normal chamber size with a normal EF. And this is the 12 ECG. And this is the documented tachycardia from other hospital.
Okay. Anybody have comment? Seo?
With narrow tachycardia with about 150, and I think the current morphology is similar to the earlier one.
I don't think it's 150.
Yeah, about less than 150. Between the 100 to 150.
It's relatively slow as a usual SVT, right? Okay. Then
I'm looking for a QA.
Maybe some notches in here or here. It could be QA, but I'm not sure. Anyway, it could be the short RP tachycardia.
You can sure.
Yeah.
Okay. EP is all one now. Okay. Please be straightforward.
So yeah, my conclusion is short RP tachycardia.
Was prominent to Richmond QA, right? To Australia and QA. And can you localize the bypass track or a Canadian LP based on the QA quality? One.
I would say it's an intermediate architect cardiac because the wave is not very short. The downward notch before the T wave is likely to be wave, and it's quite broad. It's more than 70 milliseconds. It's not a typical short architect cardiac. It's an intermediate architect cardiac. T waves are negative into T wave. So we're not localized bypass track on during ORT because during ORT the conduction is from in autonomic ORT, the conduction, anti-gate conduction is to the AV node, and the retrograde conduction is to the bypass tract. So during ORT, we cannot say what location is that.
But if it's ABLT, you find some left lateral is prominent. Negative POA in B56 and lead one ABL. Okay. Yeah, I know it is difficult to differentiate the polarity of the QA overlap with the segment, but if the always negative ECG wave suggests the location of origin, right? So if it is a left lateral bypass tract, lead one ABL, B56 should show negative, but I don't see that here. Okay. So do you see any prominent negative P wave here, except for to say wave? How to say? Okay. Any other comment? You should play a role of Dr. Chong say. So even though it is a simple total ECG, you try to find out more information, useful clinical information as much as you can. Okay, let's go.
And this is the chest X-ray, and there was no significant finding. So we do the EP study. This is the baseline catheter positioning of the LAO and RAO view. And this is the initial sinus rhythm. Cyclings was 812 and AH interval 57 and HV 50 and QRS duration was 75. So we did the V-pacing first, and when we conducted the V-pacing 600, the earliest retrograde A was observed at the HIS. But when we go down to 400, the earliest retrograde A signal was on the H5 or 6. And the VA block cyclings was 300. And there was no decremental property during the single V test. When you go down to 600, 320 milliseconds, there was the sudden VA prolongations, and when you see the atrial retrograde atrial sequence, the sequence is changed, and the earliest retrograde A also changed a little bit.
I wonder, this one the catheter is located at the proper position. Website canal. I know that, but the basically left during BPC default, right? Why A sigma is so big? Website. Yeah, let's go ahead.
So we did the atrial pacing 600. And AB block cycle length was the 320. And there was no AH jump. But there was HV delay, and the QRS morphology was the LVBB when you give the S2. And when we do the single A test, 600, 300 milliseconds, there was 2 echo beats. And the earliest A was the 878 or 56. Also, when we go down to the 600, 240 milliseconds, there was also the one single echo beat, but comparing with the previous one, the VA distance and the retrograde ATR sequence and the earliest A location was different from the previous echo beat. Also, when we go down to 600 and 220 milliseconds, the similar one echo beat was observed. The tachycardia was not induced, so we used the isoprotenolol, and when we got doing the single V test, 500, 240 milliseconds, there was also the VA prolongations and the retrograde ATR sequence change, and the earliest retrograde AT was also different. The tachycardia was induced during the double test 450, 300, 230. But during the tachycardia, the QRS morphology and the tachycardia cycle lengths keep changing. When the tachycardia with the RBBB morphology, the cycle length was 240 and AH 99 and HV 58 and VA 77 and QRS duration was 104. And this is the surface ECG when the tachycardia with the RBBB. And when the tachycardia with the LBBB, the cycle length was 254, AH 70, and HV 62, VA 111, and the QRS duration was 103. And this is the surface ECG with the tachycardia with LBBB. And when the tachycardia without the bundle branch block, the cycle length was 244 and AH 96 and HV 54, VA 76, and QRS duration was 65.
How was during LVB? Long, like 254, now 240.
And the without the bundle branch block is 244. And this is the surface ECG without the bundle branch block. But according to the Commons law, the bundle branch block ipsilateral to the true accessory pathway should prolong the tachycardia cycle length. However, in this case, our left-sided accessory pathway was suspected, yet the cycle lengths appeared longer during the RBBB. But looking more carefully, the AH interval increased and significantly during the tachycardia. Therefore, the longer cycle length during the RBBB was mainly due to the AH prolongation rather than the bundle branch block itself, resulting in an apparent discrepancy from the Commons law.
That's interesting, right? But Commons law usually applies to female pathways, not second pathways.
During the tachycardia, V reset was not observed. And delta AH interval was over 40. And at the time of the termination of tachycardia, it ends with the A and without the following V. So we put the quadripolar catheter deep inside the CS and do the LV pacing. And when you're comparing to the STEAM to A interval during the LB or an RV pacing, it is the 121 milliseconds at the RV pacing and 105 at the LB pacing. So in summary, the earliest retrograde A was at CIS or CS5 or 6 alternatively during the RV pacing. No decremental property, but the VA interval prolongations and the changing of the retrograde A sequence and the earliest retrograde A were observed during the V stimulus test. No age jump during the A study, but the HV delay and the LVBB morphology at the S2 observed in the single A test. Ecobit was observed at the single A test with earliest ATR activation at the CS5 or 6 or HIS. And during the tachycardia, V-reset was observed, and delta AH was over 40, and tachycardia terminated with the last ATR electrogram without the subsequent V. Variable QRS morphology during the tachycardia with the earliest A consistent at the CS5-6. So in conclusions, we diagnosed this with the orthodromic ABRT with the left posterior subtle accessory pathway.
Okay, at this moment, do you have any question about the diagnostic procedure? No question? I wonder you saw we saw the prominent retro PA surface ECG.
Mhm.
The V interval was very short. Did you see the similar finding? Study?
With comparing with the clinical one.
Yeah. Clinical ECG, the documented actual ECG shows. We saw the prominent retro PA. This is now.
But when it's
Now,
Without BB.
when it's it is more likely with the clinical one when you see the 2-3 AVF negative P wave. Yes, because it is under the isoproteinuria fusions. So
anyway, we still see the retro PA delete too. Right.
yes.
Yes. What?
So at first we put the ablation catheter at the left side. We did the septal puncture and used the deflectable sheath. But when we checked the ablation catheter signal, there was no earliest retrograde A on the ablation catheter at the left side. So we did not did the ablation at the left side. So we plan to approach through the CS. So at first we did the CS angiography. And we put the ablation catheter inside the CS. And before starting the ablations, when we put the ablation catheter inside the CS, the earliest retrograde A signal was observed at the ablation catheter earlier than the retrograde 856, 23 milliseconds. So we start the ablations. When at 3 seconds after starting the ablations, the retrograde A sequence changed and the retrograde earliest A signal was slightly moved backward, so it changed. And there was the VA conduction block observed. So it terminated at 3 seconds after the ablations. And as you can see, comparing with the starting point and after the ablations, the earliest retrograde A signal is changed, and the sequence of the ATR retrograde A is also changed. After the ablation, we conducted the EP study again, and there was a VA decremental property at the single V test. And also there was the AH jump at the single 8 test 600, 270 milliseconds. And this is the post-ablation ECG. Thank you for your attention.
On the electron looks so ugly. Very strange. Did you increase the gain?
I increased the gain to show you.
Oh, that's why. That's why it is so ugly. Yeah, you increase the gain and the cut of the amplitude, right?
Because I have to check the retrograde AC point
Mm.
more earlier than the 85%.
So you made it. Okay. Okay. Let's go back and look at the electron one by one. Okay. Go ahead. Okay, previous one. So HB interval is pretty long. Oh, 50 milliseconds. It's okay. Yeah, and oh. Let's see the echo beats. Okay. So whenever you see the echo beat, the QRS looks like the LBB pattern, right? And the sequence is same. Looks same.
Yeah.
And the U shows the reset the wide QRS change to narrow QRS.
Yes.
Episode of wide to narrow QRS. Can you show the slide? And the previous one. Oh, it's RBBB, right?
Doing the change of
There was another electron tachycardia, RBBB. Okay. So now tachycycline 240, then narrow QRS 244, while the LBB pattern 254. Mm.
reverse.
So why AH intervals prolonged here? Anybody can explain it? It's reverse Kuhlmann's law and the interest finding. If it doesn't match to the basic knowledge of Kuhlmann's law, we need to measure the AH interval. AH interval prolonged. That's why the tachycyclines was not shortened, right? And we should explain why AH interval changed and QRS became narrow. If you look at the transition time, wide QRS, in between wide QRS, narrow QRS, there's intermediate fusion shaped QRS morphology. Okay, let's try to explain it. Anybody? Seyo? Stay closer to the screen. First question is why AH is prolonged. The second question, when longer AH interval, why QRS became narrower? The PVC or something?
Could you measure the AA interval? Looks a little bit shorter after the intermediate QRS. No?
해보세요.
Uh,
Yes. Dr. Deonkin?
Yeah.
Oh, I see.
A little bit narrower than the previous year.
It looks some kind of fusion happened. Not fusion, resetting happened
So what
between wide QRS and narrow QRS. Right?
what event make reset the tachycardia? Is it natural finding? Usually when we deliver some extra beats, that change the wide to narrow to wide. What is the spontaneous change with fusion beat?
Mhm.
Okay, then second question. When the age interval is prolonged, why the QRS change to be shorter? I think it's easy to explain.
Yeah,
When
that's
the
easy because
age-
the difference in age from the wide QRS 121H and to the narrow QRS 184 is around 60 milliseconds. So a wider H allows recovery of the His-Purkinje system and
Mhm.
conducts with a narrow QRS.
So enter the AV node conduction delay
Yeah,
by AH prolongation
allows
make a longer
His-Purkinje.
refractory the recovery time from refractory period. Okay. But still, I don't know why the QRS rhythm changed narrow QRS spontaneously in this patient.
So the only explanation would be in the integrate circuit of the tachycardia,
Mhm.
not in the retrograde circuit.
I think
Retrograde circuit will not affect QRS
Mhm.
duration. So when the patient usually likely has a dual AV nodal physiology when the integrate conduction jump from one slow pathway to the other spontaneously, it prolong the AH.
That's my question.
Hmm.
There's no spontaneous.
Oh.
There should be some input.
Something that
Yeah.
makes it shift to the other.
Dr. Huang?
I'm not sure what makes the intermediate fusion or kind of reset.
But the V electron looks similar and regular. Of course, it changed a little bit later, and the first part, probably the cathode position change.
was the AV block cycle length? The AV block cycle length.
So for the fellows, if you see this kind of keep changing tachycardia, so if you break your mentality, you will misdiagnose. So please stop screen and carefully watching one by one. And I will give you one tip. If there is a VA linking, keep conscious VA linking. You can see the VA linking in Utica-polar catheter, CS proximal area.
Mhm.
I think it's the bypass tract or SVT. If it is VA linking is broken, you need to think about other tachycardia, AT, JT, or some other things. Okay, so of course there is some unusual bypass tract showing the decremental property, but if the V interval is short and same, you can trace as potential bypass tract. Okay.
There is one finding in this AT study which rules out AT for definitely is that termination with A without going to V. You said that.
Which one? Let's go.
You said in your summary slide there was one
Combination episode.
termination A without going to V.
Okay.
So this rules out AT.
You cannot rule out.
Usually it rules
Probability is AT
because
is
it's very
less
unlikely.
likely. Less likely. So we saw the A no B phenomenon favors SBT, but even 80 patients, sometimes they show like this. So there's probability, is SBT probability high, but not always. So EP is interesting. Always there's exceptional findings.
But the antegrade block cycle length was around 320, and the tachycardia with the LBB was at a cycle length of before where it switched from LBB to narrow complex. Yes, was at 300. So hypothetically, could it be that the fast pathway may have blocked over here, and the propagating wavefront then conducted antegradely across the slow, which was what accounted for the prolongation in the age interval? I don't know if hypothetically that is possible. Because if it was consistently going through the fast pathway, and we saw from the A study that the blocks. This ISO, okay.
Are you talking about memory phenomenon?
No, I'm not sure if that's no, I'm
keep the fast tachycardia. So refractory period of left bundle branch shorter and shorter. It's gradually shorter. And LBBB, it came out from the LBBB, make a fusion, narrow crest. Then it's difficult to explain the reason for the AH prolongation. Okay. So this is homework. It's possible. So the recovery from LBB by memory phenomenon, and easier to come back to hit the AB node earlier, little earlier than during the LBBB. So make a prolongation of AH jump. But it is also hypothetical. That we don't know the reality. Okay.
Because it looks like this.
Okay. Copy use California on the screen.
This RR is shorter, so the conduction prolonged here before this intermediate one.
Oh, is it longer? Really?
Yes, this is probably too wide for the calipers, but
Don't break your caliper.
we have this is the RR, and then we have this. So it's prolonged slightly, maybe by a few milliseconds. So there's a slightly slower conduction. So I think something must happen at this side, which slows the conduction. Then here we have a fusion because there's some partial recovery. And then here we have full recovery, giving us the narrow QRS.
So please send circulate this EGM to us, and let's think about the potential mechanism. That is the beauty of electrophysiology. So we can hypothetically think about the mechanism, invisible mechanism in your brain. Okay, so can you show one or two more interesting findings in your presentation slides? We already saw it in a long time. Any other things?
Can you show us when you ablated?
Yeah, the ablation signal looks good, but actually I failed from LA left side endocardial ablation, right?
When it's
Are you inside CS? Okay.
The left side.
probably at the mouth MCV, it's got.
Even
Why the ablation signal is so ugly?
if so small LSI, so it is hard to contact them.
My fault.
Can you show the VA separation at ablation? What is VA block? Intermittent VA.
Yeah, because this post-receptor bypass tract, the atrial sequence through the bypass tract and the AV node is similar. So sometimes it's difficult to notice. But I think the polarity of H15, 16 is different, right? So it is coming through the AV node. Okay.
So when there is VA block while ablating, how can we be sure we are not damaging the conduction system?
If you see the complete VA block, it is conformative. You ablated the bypass tract successfully. But if the young patient who has the very good VA conduction through the AV node, sometimes you see the VA conduction. But usually the endpoint should be, as you see the VA block by changing your V pacing rate. Okay.
So in this case, I believed in myself, and I stopped the pacing and observed the antegrade AV conduction for safety.
That's my.
So how many burn Dr. Kim did?
Only one.
Only one burn.
Unusually, only one.
Not two burn? In the left side, you didn't.
Oh,
just CS ablation.
only 150 seconds ablation.
That's good.
How was the power?
The same. Don't irrigate its catheter, 50 watts.
50 watts.
And it was really painful for patient. So
Yeah,
be
Dr.
careful.
The published paper, if the bypass tract location is within 1.5 centimeter from the CS ostium, you can ablate from inside of CS, not always transseptal. But that posterior septal bypass area is some patient has multiple atrial insertion. So don't forget to map the right side posterior septum and left side posterior septum one by one. Otherwise, even it was successfully ablated in EP-lag, some patients recur tachycardia. Actually, I have a long time ago, almost 25, 30 years ago, I met a similar right side posterior septal bypass tract, and we ablated 4 times. And the last successful ablation site was left side posterior septum. So those patients has 2 separate atrial insertion to right and left side. But I think the ablation distal signal was beautiful. It shows a beautiful pathway potential. Yeah.
I also mapped the right side and left side, but there was no interesting potential like this.
Okay. Any other comment? Question? Dr. Om? Why you are so quiet today? Okay. Thank you very much, Dr. Chair, and everybody. Have a nice weekend. Sign up with the
맞아.
그래?